Hello everyone, and welcome to today's webinar from the Public Health series on blood disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention. You would probably know that as the CDC. My name is Eddie Lang, and I'm an emergency physician and the department head for emergency medicine at the University of Calgary in Alberta, Canada. It's a real thrill for me to be with you and serve as today's moderator. The topic is a really important one for me and others in emergency medicine, and it's all about venous thromboembolism, VTE, and the focus will be on management in the emergency department. And I am thrilled, and I think we are all really lucky to have a renowned expert in the field with us, and that's Dr. Jeff Kline from Indiana University School of Medicine. Let me cover a couple of quick housekeeping points before we get going. Before I introduce the guest presenter, what we're going to do is we're going to tell you about the audio options for joining the webinar. You can, of course, listen to this through the speakers on your laptop, or if you're in a group setting through a single computer, or you can phone in. And the phone-in options are going to be seen part of the webinar toolbar that'll appear on your screen with the phone number and access number and audio pin. All audio will be muted to improve sound quality, but at the end of the presentation, there'll be hopefully lots of time for questions, and you can submit a written question using the questions area of the toolbar. And we'll get Dr. Kline to respond to those as time allows. So we're set for a webinar that's going to last about 1 hour. And of note, this is going to be recorded, and on Dr. Kline's very last slide, you will see the website where you can access the archived version. So we'll begin first by getting to know you guys a little bit and our audience. We want to know a little bit more about you, and we're going to use the polling function of the webinar to find out a little bit about what you do. So from the online poll option that you should be seeing now, select your primary professional role now. And let's see what that's showing. So if you can all attend the poll. And click on the choice involved. And we'll get those results and see that momentarily, I believe. The other question we have for you is really, I think that was it. That was the main one to find out where you're oriented. So let me get right to business. And we will get Dr. Kline introduced and giving his presentation. So Dr. Kline is well known to those in emergency medicine circles. He's the Vice Chair of Research at the Department of Emergency Medicine at the University of Indiana School of Medicine. He conducts clinical and translational research to improve the therapeutic index of the diagnostic evaluation for patients with possible VTE and treatment of patients with proven venous thromboembolism. Dr. Kline's research focus is on screening, risk stratification, and the treatment of pulmonary embolism, and many of you will know him as well as the editor-in-chief of the newly revamped journal Academic Emergency Medicine, arguably our specialty's premier research journal. Dr. Kline is also a member of the Medical and Scientific Advisory Board of the National Blood Clot Alliance. And my apologies, there was a second question about regional, where you're from regionally. I don't know if that made it up onto the screen, but if you could answer that one, that would be great as well. But for now, Dr. Kline, welcome, and let's begin.
All right, thanks, Eddie. It's great to be here, and I'm going to talk about kind of 20 years worth of interest in my professional life and my practice of emergency medicine. I'm going to bring this home as a practicing pit doc, but try to give some evidence about how to approach this problem in the emergency department. Here are my disclosures, and what I would like to talk about are risk factors for pulmonary embolism in the emergency department, how to rule out pulmonary embolism without imaging, and talk about risk stratification in particular to allow us to send patients home and free them from the tyranny of hospitalization. So let's get started by thinking about being in the emergency department and seeing a symptomatic patient down here at the bottom of the screen. And what is going to increase or decrease the probability that this symptomatic patient is going to end up with a diagnosis of pulmonary embolism in the next couple of months? And that's like an individual case-by-case basis, rather than thinking about longitudinally studying thousands of patients, like in the upper part of the screen, over a period of time. So the risk factors that increase or decrease risk in a symptomatic person that raises any gestalt or intuitive suspicion of pulmonary embolism are different sometimes than they are in the general population. And so that leads to this slide, which shows that there are some things that we may think are big risk factors because they increase the risk in the population that may not so much increase or decrease risk in the emergency department. Over on the left-hand side, let's look at these things that definitely increase the probability of the diagnosis of pulmonary embolism in somebody that raises the suspicion in any physician who's awake and fogging a mirror and starts to thinking about possibility of diagnosis of PE in a person who has selected him or herself to come to the ER. And that includes recent surgery. Recent is generally defined as within the last 4 weeks and requiring general endotracheal anesthesia or epidural anesthesia. Prior venous thromboembolism, virtually every database increases probability. Estrogen use, actually of all things, non-O blood type. Extremity immobility and more joints that are immobilized that increase the risk. This does include even shoulder immobilization. Being postpartum, especially less than 5 days, and active cancer. Those are all certain. Over on the other side, these are some things that we can argue and we can't say for sure. Everybody thinks if you get on a plane and are on the plane for more than 4 hours or more than 6 hours, it increases your probability of DVT and probably PE. Well, that's probably true compared to somebody who does not get on a plane, for example. But if we take patients in the emergency department who report recent travel, that's less of a strength of a risk. I mean, in part because if you consider people who are able to travel, in general, they're pretty healthy people compared to many others who raise the suspicion of VTE in the emergency department. Likewise, smoking, not good in the population, but in a symptomatic patient, the problem's more likely airways than it is the pulmonary vasculature. Obesity, very weak in the emergency department, but strong in epidemiologic studies. And family history, there's different types of family history that's certain and that's not. Pregnancy also, everybody knows it increases risk in the general population, but not so much in the emergency department. And some of these other things I've listed, like lines, infection, nursing home status, or being in a extended care facility, less certain. Same thing with heart failure and AFib. Patients that show up with heart failure, most likely, if they're short of breath, they've got heart failure, not a PE. Let's just look at one in particular that raises a lot of question, and that's pregnancy. And this is a meta-analysis published about 2 years ago, 2.5 years ago, looking at the relative risk of the outcome of diagnosis of patients that triggered a workup. And the minimum workup could be a ddimer in this study. And the bottom line is that pregnancy actually led to a lower likelihood of final diagnosis of PE. What this shows is that we have a very low threshold as emergency physicians and advanced practitioners for triggering the workup for pregnant patients. There's 2 patients, and one of them being the most vulnerable, and so there's a lot of, I guess, emotion that goes behind this. And as a result, even in the 3rd trimester of pregnancy, that you can't show any increased likelihood of the outcome of PE. And even in age-matched patients, the probability of diagnosis for pregnant patients is lower than age-matched patients. And I think that just shows that most patients that are pregnant have a very low probability of PE. Immobility is likewise one that fakes people out. If you look at travel there in the middle bar compared to other types of immobility in the emergency department, much less of a strong risk than generalized immobility or limb immobility. So some of the things that we sort of walk around thinking about as risk factors of VTE, like pregnancy, obesity, smoking, are not so strong of risks in the emergency department. How about some things that can help us when we go talk to the patient? One that shows up in virtually every database is unexplained dyspnea. What does unexplained mean? Well, it basically means they don't have COPD or asthma, heart failure, or any other cardiopulmonary problems, and now they've shown up with new onset shortness of breath. One thing I want to tell you from having reviewed maybe more than 100 medical malpractice cases with allegations of negligence from failure to diagnose pulmonary embolism, that one of the things that docs miss is sometimes patients aren't short of breath when they're sitting there and there's somebody else in the room, maybe a family member, a spouse, a friend, a mom or dad, or a son or daughter, telling you the patient is short of breath with walking. So new onset of dyspnea with exertion can very well be pulmonary embolism as well as heart failure. So unexplained dyspnea. Pleuritic chest pain, yes, a significant predictor. Substernal chest pain, no, in fact, probably points away from PE. Syncope, controversial with the most recent New England Journal paper that came out of Italy. I'm going to say that I'm going out on a limb and tell you that the world's literature is ultimately going to prove that syncope in the emergency department is probably not a significant predictor, reflected somewhat in the fact that no pretest probability scoring system such as the Wells score or the Geneva score includes syncope at all. Hemoptysis always and consistently increases probability. And dizziness, well, that predicts nothing except that you're going to try to pick up the next chart. Let's compare a couple of risks here from a large study that included about 8,000 patients. There's dyspnea. That's unexplained dyspnea, odds ratios of 1.6, pleuritic chest pain 1.4, estrogen use 2.2, but you can see substernal chest pain over here at 0.5 actually decreased risks. These are just some magnitude of effect odds ratios to show you the probability of the outcome of diagnosis for a couple of risks or symptoms compared. How about physical findings? Heart rate consistently increases risk, respiratory rate less so. Pulse ox less than 95%. Be careful of that one. Know it at triage, and don't just look at the pulse ox on oxygen. Look at the lowest one. If you're practicing in Salt Lake City or in Denver, you probably need to change that number to 92%. Systolic pressure less consistent. Temperature, you always hear PE might cause fever. Maybe it does. No one knows for sure. My own personal belief is PEs with fever actually have an infection that's not diagnosed. Nothing in the literature or any decision rule about increasing the probability. And then rigid affect is something that's a particular research interest of mine, and it's when you look at a patient's face with pulmonary embolism, do they have a decrease in affect variability? And that's something that's a maybe, and just a subject of research. How do we go to the bedside and use our intuition to know whether a patient is sick or not sick, and based on their affect recognition? It's just something in work that I bring up. Vital sign trends, a lot of times at checkout, you'll talk about patients' heart rate normalizing. Well, unfortunately, if you look at it quantitatively, patients with PE will normalize their heart rate or lower it just the same as patients without PE. Not something you can really hang your hat on, the old normalization of heart rate. And then this is just some data that I'll just throw out here for fun, where we took patients and videotaped them prior to them getting their CTPA scans and did this fancy thing on them called the facial action coding system to determine if they had different affect than patients who were not diagnosed. And lo and behold, it turns out that patients with PE have less facial variability when they watch a standardized, allegedly humorous stimulus. So maybe it just backs up that thing at the bedside when you sort of walk away and say, patient didn't look quite right. That's part of what I'm trying to dissect here by looking at patient's affect. In fact, it may turn out that smile actually sort of fakes us out, and this sometimes is not 100%, meaning that if we ask physicians, do you remember if the patient smiled during your evaluation, We were surprised to find out that patients with PE were recalled to have smiled more frequently than patients without PE. These were the ones that were ultimately had a positive CTPA scan here. We think the reason for this is something called the obligatory smile. And it is the fact that patients with actual PE are really quite happy to have been taken seriously, since many of them had their first encounter with healthcare providers and had their PE missed, that they're really just happy to be taken seriously. So sometimes even the smile can fake us out, even though overall, when watched surreptitiously, patients with PE have a different affect than those that don't. Other physical findings that are more certain: wheezing decreases the probability of PE, and unilateral leg swelling consistently increases. Chest wall tenderness, although decreases probability of acute coronary syndrome relatively consistently, not so good with PE, especially with pulmonary infarction. So here's one thing I want to throw out there, and I keep saying it, and it keeps saying it enough, it's going to make it true, and that is that it is reasonable and prudent to exclude pulmonary embolism from the differential diagnosis if the patient has no shortness of breath in the present history or review systems, including no dyspnea on exertion, no chest pain at all, with vital signs normal at all times. Right there, that is reasonable and prudent, no matter what other risk factors they have, to not launch in the workup of PE. But for others, we need to use a more structured criteria, and the pulmonary embolism rule-out criteria, or PERC rule, may be helpful. Now, the PERC rule is designed to be responsive to the concept of something called a test threshold. And that's a line in the sand where if you have a patient with such a low probability, it is not beneficial even to order a ddimer, because there's a 50% or so probability that the patient doesn't have PE will have a positive ddimer leading to a CT scan, which can have downsides: radiation exposure, contrast stress on the kidneys, maybe even a false positive diagnosis and put on anticoagulation they don't even need. The test threshold is derived from an arithmetic equation that was described by Pauker and Casserer in the New England Journal in 1987, and it has assumptions in it, such as what is the risk of death for untreated PE that we don't really know the answer to. But the bottom line is that at a threshold below 2%, it can be predicted that we do more harm than good by even ordering a ddimer. So the test threshold is what we try to be responsive to for criteria to rule out PE without a diagnostic test. And the PERC rule will do that. The PERC rule requires you, as the physician, to say, I have a low gestalt suspicion. What does that mean? It means that you think there's less than a 15% probability that this patient has PE, plus these 8 criteria that you can see there. As long as they're under age 50, by the way, I flunked the PERC rule now. Heart rate less than 100, no hemoptysis, no estrogen use, no recent surgery, no prior VTE, no unilateral leg swelling, and a pulse ox always above 94%, then you don't need to work up PE. Now, the single most important thing that I have to say in this talk is don't memorize the PERC rule. Don't memorize any decision rules. You've got better things to do. If you really feel the need to memorize a decision rule, I suggest you do 10 push-ups. That's more useful to you than memorizing a decision rule. Look them up or use an online calculator such as MDCalc. Now, if a patient flunks the PERC rule, or you have a above 15% gestalt pretest probability, the next step is to consider using a ddimer. There's at least 4 ways you can use it. One is a Wells or Geneva score less than 5, and that's a simplified, revised Geneva score. Don't have time to get into the exact details, but be careful when you look at that. There is the Geneva score, the revised Geneva score, and the simplified, revised Geneva score. Either that or a Wells less than 5. Negative ddimer rules out. There's also the Charlotte rule, and just using your gestalt less than 40% non-high pretest prob is good enough to rule out ddimer. Let me show you these data to make sure you believe me about gestalt. This is a meta-analysis done by Will Lucason a few years back that indicates that your gestalt is just as good as a non-high probability wells or Geneva criteria with the sensitivity and specificity shown there below. So just asking yourself the question, do I think this is a non-high probability patient? It is reasonable and prudent and adequate to rule out PE with a negative high sensitivity D-dimer plus non-high pretest prob. And sort of logical extension of that, it's oftentimes asked, what about adjusting the D-dimer for age? I'm here to say that I believe that adjusting the D-dimer, if the standard threshold is 500 nanograms per ml by 10 times the age, is ready for prime time. It's ready to use. It yields about the same likelihood ratio negative, maybe even a little lower likelihood ratio negative than the standard cutoff. And I like these real world data from the Kaiser system that looked at a large number of patients with D-dimer, over 30,000. And what they found was the false negative rate at the standard cutoff was extraordinarily low, 0.06%. And if you use the adjusted cutoff, it goes from an extraordinarily low to a very low probability that you're going to send a patient out with PE. And from my experience and everything that the meta-analyses have shown, this is a true statement. It is reasonable and prudent to send a patient home with an age-adjusted D-dimer. So that leads to an algorithm for the diagnosis and exclusion of PE. We start off up here at the top, where we say, does the patient have a sign and symptom of pulmonary embolism? And if they don't have either, that was the first thing I started off by saying, no chest pain, no dyspnea at any time, and normal vital signs, then no PE. Now, this is not to say they don't need a DVT workup, because if they got signs of DVT, you might need to do an ultrasound. But if they don't have any other findings, no PE. And if they do, and you have a low gestalt or even a well score less than 2, it's reasonable to use the Perc rule. If the Perc rule is negative, you can stop. Otherwise, move to a D-dimer. If the D-dimer is less than normal threshold or age times 10, no PE. So we can get away without imaging a lot of patients just using clinical criteria at the bedside and or a D-dimer. Now, if we flunk the D-dimer and we have to move on to get a CT scan, I felt that there is at least enough importance for me to get across the idea that it is incumbent upon emergency physicians to have some idea of the CTPA quality before they either diagnose or rule out PE. When it comes to diagnosis, especially when you kind of had a borderline pretest prob or a very low D-dimer, realize that all PEs on CT scan are not created equal, and beware of low quality scan. First of all, because you may end up causing anticoagulation and the psychological worry and the cost and the hassle of anticoagulation for a patient that never had PE in the first place. So it's really good to know about your scan quality from your emergency radiologist, both for positive CTs in the presence of a you didn't think they had one probability, and also if you really think the patient had a PE, or they had a super high D-dimer and had the old PE stamped on their forehead, clinical presentation, recent surgery, tachycardia, low pulse ox, no prior lung disease, and pleuritic chest pain, and the CT comes back negative, ask your radiologist about the scan quality. What about subsegmental, isolated subsegmental PE? If you look at clinical guidelines, more and more experts believe that it is reasonable to not anticoagulate patients with isolated subsegmental PE. Now, when it comes to scan quality, I just threw a couple of examples in here. Look at the scan on the left. Everybody, including their mom or their non-physician friend, can see this big saddle embolus with the yellow triangles pointing to it on the left-hand side. That's a huge clot, easily seen in the bifurcation of the main pulmonary artery. However, over on the right, there's a yellow arrowhead pointing to sort of a weird shaped triangular defect in the left main pulmonary artery. Is that thing a clot? Is that a web? What is that? That thing was read as positive by a radiologist. And I'm not positive that I would want to be treated if that were the thing in my lungs. So I just show these as two examples, one where there's certainty and the other where there's diagnostic uncertainty. sometimes you need to talk to your radiologist to find out how certain they are before we commit a patient to anticoagulation, or we send a high-prob patient out with a negative CT scan. Now, let's say that we've diagnosed PE. Let's move on to a new aspect, and that is treatment. Well, here's some treatment options of patients with PE. Those that can go home, those are the lowest risk. Those that need to be admitted for anticoagulation or either systemic or catheter-directed lysis, or those that are really sick that might need life-saving intervention like extracorporeal membrane oxygenation or ECMO, or even a Trendelenburg operation for surgery. Well, I'm going to focus only here on the lowest risk patients just because of time and sort of the scope of what we're talking about, to present a somewhat new concept that is sending PE as well as DVT home with monotherapy anticoagulation. That means a pill in the emergency department, don't need to give them a shot anymore, and then pills that they go home with. Now, who can go home with PE that is low risk? And that's either using the negative low risk modified Hestia criteria, or something called the Simplified Pulmonary Embolism Severity Index, the PEzzi score negative, plus physician judgment. And this is easiest done with apixaban or rivaroxaban, since those are the only two new oral anticoagulants that can be used without a heparin run-in, or at least they're the only ones that are cleared by FDA to be, quote, dry started without any heparin to begin with. Here's some precedent literature on doing just that. The immediate discharge of patients from the emergency department that have both DVT and PE. If you want to learn more about this, there's a Twitter link over there on the right that gives a white paper that I call Outpatient VTE for Dummies, and it is a step-by-step guide on how this can be done. This URL has been accessed more than 5,000 times. And down here in the lower left is a description of how a protocol with a clinic that is run by PharmDs can be set up out of an emergency department. So just some innovations to help get our patients out of the emergency department and home. Risk stratification. The simplified PEzzi score gives 1 point for any of these things. Any 1 point flunks the patient, too high of a risk to go home. The simplified PEzzi does not think about other comorbidities or social aspects or psychiatric illness, such as, let's just say, delusional behavior or alcoholism or homelessness. There are lots of other things that can flunk a patient from going home, either with DVT or PE, that are not covered by PEzzi. For that reason, I use the term PEzzi plus clinician judgment to send a patient home with PE on monotherapy. The Hestia criteria, on the other hand, is more of a checklist, and it does start to think about things the way I know I need to think about them in the pit when I'm getting ready to send a patient home with VTE, such as down here, no medical or social reasons to admit, like I just mentioned, or severe pain. In fact, patients, the most common reason they bounce back after being sent home with either PE or DVT is chronic pain that has nothing to do with the clot. But the problem with the Hestia criteria that I see is that the need for the only problem that I see with this is the need for intravenous narcotics greater than 24 hours. That kind of doesn't make sense for me sending a patient home to the emergency department. So we modified it like you see here, with the two bolded criteria being the slight modifications. First of all, we say they have to have a pulse ox greater than 94% and no more than 2 doses of IV narcotics in the emergency department, plus all of the other criteria that you can see there. So it's more of a checklist that includes some of the common sense things, such as social reasons to admit. Get asked about biomarkers a lot. Here's what I do if the patient is Hestia negative and has a borderline troponin, is I put them in the observation unit for 23 hours and all of them go home and all of them are fine. There's no reason to add BNP. In fact, there was a randomized trial that gave about 400 patients just the Hestia criteria or the Hestia plus BNP, and there was no significant difference in or benefit to adding the BNP to the Hestia. Jimenez et al. Has found a little bit of addition to adding BMP to PEzzi, however, but that's not PEzzi plus clinician judgment. Cancer patients probably need a belt and suspenders approach before being sent home from the emergency department with PE. And there's two ways you can do that. One is with something called the PEzzi criteria. The other is the Denexter criteria. Either one will work. These just need to be added to either PEzzi or PEzzi. By the way, PEzzi flunks everybody that has any history of cancer. So you really can't use this with PEzzi, but you could with Hestia. And here are the PEzzi criteria, and then down there is a link where you could go and see it in a little more detail. Just some experience. What do people bounce back for if you send them home with PE? One is pulmonary infarction, and they come back for pain. So if you have a patient with pleuritic pain and the radiologist says this looks like an evolving infarct, here's what I suggest you tell the patient. You're going to hurt for about a week. It is okay to take a couple of days worth of ibuprofen. You're not going to bleed to death if you add it to a NOAC such as Riva or apixaban. And expect that your pain will hurt a little more in 2 days, and then finally it'll get better in about a week. Rarely patients with PI hurt for weeks at a time. Some do. Most are better within a week. The other area I worry about is pulmonary hypertension on ECG that might not be picked up by any other decision rule. Here are some criteria that show you what pulmonary hypertension looks like in the setting of PE. These patients often need more, and especially might need to be considered for something called CTEPH, chronic thromboembolic pulmonary hypertension, and that may need more treatment than just anticoagulation. Here's an ECG showing you pulmonary hypertension from PE with the S1Q3T3 over there in leads 1 and 3, as well as evolving right bundle branch block up in AVR, and biphasic T waves trying to flip over, and the more that those T waves flip, the higher the pressure in the right ventricle. So flipped T waves V1 through V3. One last thing is your intuition, back to the face, back to looking at the patient. Those that have delirium, that get altered or have inattention or distraction, that show you this look of fear on their face in particular, that is something to pay attention to and not somebody that you want to send home. So you do need to listen to your spidey sense or think about your spidey sense. If you look at a patient and you say, man, this patient is starting to look panicked, and that's probably someone you don't want to send home. Here are our treatment options in terms of anticoagulation in the emergency department. Unfractionated heparin, enoxaparin, we're well familiar with. Not so many people realize you can give a pill of rivaroxaban, and it actually is absorbed faster with food, apixaban with or without food, and you'll get peak blood levels, peak concentrate or peak anticoagulation almost as fast as you will with giving a shot of enoxaparin. In fact, a little faster with Riva if you give it with food. So you don't really need to give a shot anymore. You can just give a pill and get anticoagulation just as fast. And the patients are going to need to go home on those drugs because it's the only way that you can send patients home with monotherapy. In the United States, it's extraordinarily difficult to get set up for home health treatment for enoxaparin and checks for warfarin. So the monotherapy aspect has really made things easier. The protocol that we use called the Indiana protocol, again, requires low risk by Hestia or PEzzi. You do need a baseline CVC and creatinine clearance because those are needed for the drugs, and whoever follows up with the patient will really appreciate having a baseline hemoglobin and platelet count if there's some kind of complication. And then the patient just needs a prescription, access to the anticoagulant, which is easily done in just about every patient set, ranging from those that are below 300% below the poverty line, those with Medicaid, those with private insurance, and anyone with Medicare plus a supplement. Easy to get access to these new drugs, the apixaban and rivaroxaban. And then they just need a place to follow up, and they're good to go. Our outcomes so far, in my experience, is we've done about 700 VTE patients, including 150 with PE, and a very low rate of recurrence. We've had 3 hemorrhages requiring hospitalization within 30 days, and those have all been menorrhagia, heavy menstrual bleeding in women. The way we handle it is have them hold a dose. That is a common problem with probably, we don't know which drug is worse, rivaroxaban or apixaban, but it's definitely worse for those two drugs than it was for warfarin. We did have 9 patients that have self-discontinued within 30 days, and I throw this point in here almost just as a titillating point. We had 5 who came to clinic and said, we stopped taking drug because of the television ads where the lawyers are trying to claim that these drugs are causing bleeding, and so grandma told the patient that he or she needed to stop their medicine. So in summary, unexplained dyspnea, pleuritic chest pain, heart rate greater than 100, or a pulse ox less than 95 increase the risk. Prior surgery, prior VTE, and estrogen increase risk. Choose wisely when it comes to excluding PE. Use the Perc rule in those that have gestalt low risk, and a ddimer for those that flunk the Perc rule or have a non-high PE unlikely pretest probability. I believe the age-adjusted ddimer is ready for use. And outpatient treatment for low-risk VTE is within the bounds of standard of care practice here and today. So I look forward to your questions, and I'll turn it back over to Eddie to see if he's picked a few to throw my way.
Hey, thanks so much, Jeff. That was an amazing presentation. It's great to have you here, and obviously an amazing mastery of this topic. So waiting for a couple of questions and reviewing the ones that have come in, I'm going to get things going, I think, by I'm going to pick your brain and your extensive medical legal experience, Jeff. You know, in the emergency department, one thing I've observed is that when we hear about a case of missed PE, there's a tendency in our group to start CTing everybody who has a chest, which is almost everybody, which is everybody. So can you share with us your thoughts on what are the factors that lead to missing that PE diagnosis for patients coming through the emergency department?
Yeah, so I'm going to talk about the numerator, and those are the cases that I've seen that ended up with an allegation that a plaintiff's lawyer decided to take on, go ahead and file the lawsuit, and then either the defense or the plaintiff went out looking for expert witnesses. So you know, those are kind of the worst case ones in a way. Every single one of them that I've ever been a witness on is a dead patient. So it's very bad cases. And with that in mind, the most important thing I'm going to say, and this is unqualified. I have never reviewed a chart of a medical malpractice case alleging failure to diagnose pulmonary embolism where the words pretest probability showed up anywhere in the note. These are cases where PE was never thought of. It is not a case of, oh, well, you know, I used the Wells criteria and it was wrong. I used the Perc rule and it was wrong. I used the ddimer and an age-adjusted ddimer. No, it is cases where no one thought, or at least from what you can tell in the documentation, that a short of breath 19-year-old with a pulse ox of 92% who's taking birth control pills that she just started might have PE. So it's more about the failure to get it in to your consciousness and your intuitive thought process than it is a failure of any rules or any testing strategy. I think that's my, you know, underlying statement and answer to you, Eddie.
Hey, that's super helpful, Jeff. You know, you mentioned earlier in the talk about the New England study by Pandroni, I think it was, who showed a troubling incidence of PE amongst syncope patients admitted to hospital. There's also some recent literature, or at least a recent systematic review, suggesting that the prevalence of PE amongst COPD patients coming to the emergency department with an unclear etiology to their exacerbation also harbor PE about 15% of the time. So the way that translates into practice is that sometimes, at least in Canada, the admitting services are insisting on PE workups before taking patients upstairs for admissions for syncope or COPD exacerbations. Is there some strategies you want to share with us about what we can do to address this potential tendency to over-testing in those groups?
Yeah, I think that we really need a well-done what I would call gray zone or fugitive literature meta-analysis of syncope to help get a better answer. The Prandoni paper had a 16% prevalence in a very rarefied population of syncope patients who no one else could figure out what was wrong with them. They weren't on anticoagulation, so they were really highly refined. If we look at humongous databases such as those, and I'm not going to try to pronounce his last name, Dr. Vink out of Ottawa, who has some of the largest data sets of syncope patients, the probability of pulmonary embolism as the causative diagnosis is more like 1%. And he has a nice paper coming out in Academic Emergency Medicine talking about that. So if we just look at concentrated syncope, the probability of PE is nowhere near 16%. How can we change the hearts and minds of admitting hospitalists? It's going to have to require a big meta-analysis to show that the true prevalence in what I would call non-refined syncope is far lower than 16%. I think it's going to be more like 1 to 3%. So I think we're stuck. And if you're really worried about it, if you do have a new seizure-like event, loss of consciousness-like event that's not well explained, just do a ddimer. I mean, just start there. At least try not to do a CT scan, and a ddimer is adequate to rule out. So that's about the best I can do with syncope. You can rule out young people with syncope with the Perc rule. Besides that, you've got the ddimer, and we're probably, I think Prandoni caused a few more negative CT scans around the world. Now moving to COPD, that one's tougher. Let me tell you a number that a lot of people don't believe, but it is true. About 30% of patients with an acute exacerbation of COPD have a negative ddimer. So it is not 5% or 10% that have a negative ddimer, which is the perception of many of my colleagues I work with and people that ask questions. The number is actually more closer to 1/3. So the ddimer is not worthless as a rule-out tool in COPD exacerbations. What to do about that 16%? Well, you got to look at those numbers. A number of the studies are down in the 3 to 4% range, and then there's a couple that had really high rates that drove the numbers up. And I think that those particular studies, out of the 8 or so that have been done, should have been excluded in a sensitivity analysis of the meta-analyzed data. And also, what's different for me is this number of 16% is not what I see clinically. It is discordant from what I've seen in all my databases, looking at lots of different sites around the United States. The number is more like 3% in my own experience, and the databases that I've published, including the very large 8,000 patient database I referred to earlier, which had about 600 COPD exacerbations in it, and the prevalence of PE in that database was 3%. So I am way less worried about the COPD issue. If they're not getting better, they can get a CT up on the floor. Syncope is one that we need more data for, and unfortunately, we're sort of stuck with Prandoni. But remember, you can rule it out with a ddimer.
Awesome. We do have a question from the audience. We're in the over 50 club, Jeff, and we remember a time when VQs were really one of the mainstays of diagnosis. In 2017, what is the role of VQ imaging in practice? What kind of patients are we going to pull out the nuclear medicine technology for?
Okay, there's two answers to that. One is patients with at-risk renal function if they have a normal chest x-ray, are probably better served by a VQ scan based on what we know right now about kidney injury from contrast. We don't have randomized data to know if VQ spares more kidneys than CTPA. There is a randomized trial that is underway that's funded by the NIH that might help answer that question. So I think the first group are those that have at-risk kidneys and a normal chest x-ray. The second is pregnant patients. And this, again, is something that is a little bit of dealer's choice. But based on everything that I know and lots of other folks that do this, The best way that I would want a loved one who was pregnant handled, if we can't rule them out with a ddimer or other clinical criteria, is a half-dose perfusion scan only, especially if they have a normal chest X-ray. So at-risk kidneys, pregnancy, probably a VQ scan at this point where I am right now is first choice. Now, there's another part to this question, and that is the role of VQ SPECT scan, or even low-dose CT plus VQ SPECT scan. So this is some new technology that basically is turning the VQ scan into more of a 3D CT result. I believe that that technology is going to penetrate more, and we're going to see it used more and more, as long as you have a place that has the ability to use something called Technogas that is not FDA cleared yet. But I think you're going to see CT or VQ SPECT increasing in its use. And there is a cost effectiveness analysis that's out there that's pretty well done that shows that one of the cheapest ways to rule out PE in the ER is with VQ SPECT scan. And so we'll wait and see what happens in the next 5 years with VQ SPECT.
Awesome. Jeff, some of the things that the research often looks at is diagnostic yield, or the percentage of your CTPEs ordered that actually reveal a significant disease. We know there's differences across jurisdictions, and suggesting that maybe in some areas, perhaps where medical legal concerns are greater, there's a lot more unnecessary CT utilization. I was wondering if you could kind of weigh in on that and see what we can do to optimize use of that technology and really only use it in at-risk patients. And some of that may have to do with patient expectations, or Dr. Google, or coming into the emergency department afraid that they've got a blood clot because they've seen something online.
Yeah, I think that's kind of how I geared the talk, is to sit down and talk to the patient about the value of the Perc rule, that if they're negative and I don't think you have a clot, then we're going to do more harm than good by launching you into testing. I think it's when you have the patient that has expectations of a CT scan, and your clinical instinct and the available data are that they shouldn't get it, make sure they know about the fact that this stuff is, this contrast is cleared by your kidneys. We do think it stresses them. It may even cause injury to the kidney. We're not positive. And then, of course, the radiation risk, especially to women under age 40, where, with simulation analyses, there may be as much as a 1 in 300 lifetime risk of cancer. Another talking point that I think that lay people need to know is that they get 3 years worth of background radiation when they get a CT scan. And I think some patients think, oh my gosh, I'm going to aid in a CT scan. And boy, that changes their attitude pretty quickly. And that's just my own anecdotal experience. So that's some things at the bedside. Now, you started off by mentioning about variations in regional ordering, and in terms of normative behavior, what would my colleagues do, or what do we do here because of threat or risk of allegations of negligence? I'm not aware of any really well done health services type of publication showing that. I believe what you're saying is true. You do see lower use rates, for example, in Texas than you do in the Northeast, and you can get these data from the NAHAMS type database. The most important thing are for responsible groups, meaning like contract groups and academic institutions, to measure it and to show doctors what they're doing relative to their colleagues. And like many things, if you measure this, it will get better. I've seen it work, and it's just as simple as telling docs, use the ddimer more, use the Perc rule more, and here's your numbers relative to your peers. But the problem is it requires a marshal or a, sort of a sergeant at arms to keep up with these data and to follow up, because the only thing that works is if the docs know they're being watched, because otherwise they'll creep right back to their former behavior. The same thing goes for antibiotic usage, for colds, and other things that we believe need to be modified.
That's amazing, Jeff. Thanks. You know, in 2014, the American College of Emergency Physicians bought into the Choosing Wisely campaign and issued this recommendation: avoid CT pulmonary angiography in emergency department patients with a low pretest probability of PE and either a negative Perc rule or a negative ddimer. Do you think that that we've seen some traction from that? And if yes, why? If not, why not?
I think, I get a little bit of a skewed sample because I have people tell me when it works. The places that don't work, they probably don't bother to tell me. Maybe they don't want to hurt my feelings. I think we are seeing traction with more people using ddimer and using Perc rule. I actually think the problem is maybe I think it reached its worst point for CT scan of the chest for PE a few years ago, and we're starting to dig out. And there's at least 2 or 3 papers now that are out there showing that things are starting to increase a little bit from the low of maybe 3.8% reported by Feng et al. In academic emergency medicine using the Hames database from about 5 to 7 years ago. The more recent data showing the numbers are on up to about 5 to 6% overall in terms of the yield rate that you mentioned earlier. So I think things may be a little better than they were, but I have no idea if that was from the Choose Wisely campaign or not. Maybe it helped. You didn't ask this, but as a side, I think our next target needs to be low risk abdominal pain, because the last several low yield advanced imaging studies I've done, I'm really seeing low yield abdominal pain being the big issue for radiation, even more than CT of the chest, with CT of the head kind of in between the two.
Great. Well, we're coming up to near the end of the webinar, but I think if people wanted to shoot out another quick question or two, that we could certainly do that. Jeff, one thing that often comes up in discussions is the sequence between Wells and Perc when establishing pretest probability. And I think I've heard some debate on this, and I think you presented it very clearly. And I think in the algorithm, you even provide the option of either Gestalt or a very low Wells less than 2. Any thoughts on what may be the most practical and a reasonable approach on sequencing those 2 clinical prediction rules?
Well, I'll give you my common sense answer is, why not just use Gestalt? Why not? It's always there. You don't have to look it up. And if you think the patient has less than a 15% prob, boom, do it. It's been demonstrated in something like 20,000 patients now. There's a large randomized trial of Perc, no Perc that is in review. Every paper that comes out is not exactly aligned. There was one that came out of Europe that suggested a relatively high pretest prob if you use the Geneva score plus Perc, but just about everything is demonstrating that it is safe and reasonable to do together with physician Gestalt. If you want to use a Wells less than 2, that's fine. I mean, I can show you data that indicate that that's a safe strategy. It just kind of doesn't make sense because there's some overlap between Perc and Wells. And also Wells, well, the biggest majority of Wells is Gestalt. It's saying that I don't think the patient has PE most likely. They got something else most likely. That's really not a lot different than Gestalt. So I just say go for Gestalt.
Perfect. Jeff, we've got maybe time for one more question. Something's come in about something called the years strategy, and that's the recently developed clinical decision rule with direct ddimer testing. Thoughts on this, and will it reduce CTPA utilization?
Sure. This is from Menno Huisman out of the Netherlands, and a bunch of good friends did that study. I don't like that study, and I'm going to tell you why I don't like it. The way it was actually done was the ddimer was ordered at triage before pretest probability was actually done. So everybody had a ddimer from the start, and then they calculated the pretest prob. So the reason I don't like that is I would sure hate to have I don't know, like profligate testers get a hold of that and just say, well, the triage nurse should order a ddimer on everybody that has a chest, because that is actually how the study was done. Let's just say we did it a little bit differently, and we added the ddimer after we did pretest prob assessment using the modification that the Dutchman used in that study. I think that would be a great strategy. But I'm just telling you how that study was done was not exactly well understood from the Lancet paper. So yeah, I think it's great to use. I don't even know that you need pretest prob that much with a negative high sensitivity ddimer, but the one that they used is great. I just would like the order to be pretest prob first, then ddimer, not ddimer at triage.
Great. Now that question I think came in from the Netherlands, so hopefully that'll be all right. Last thing, Jeff. You know, primary care is under pressure in a lot of places, and there's some, I think emergency docs may have some hesitancy initiating an anticoagulant in a setting where follow-up is really critical. Some quick tips on what strategies you might employ to ensure that follow-up and safety are appropriate at discharge?
I think this is an issue of talking to the most likely primary care network that you're going to have in your system. In our system, we actually set up our own clinic so that we had the opportunity to see any patient, regardless of whether they had a PCP or not. But it doesn't require any special doctor to follow these patients up. They don't have to be a board-certified hematologist or pulmonologist or clotologist. Primary care physicians, family practice doctors, when we first started doing it, they weren't exactly comfortable, but now they want to do it. It's very easy to follow the patients up. They just have to have a primary care provider. So that's probably the simplest answer that I could give right here.
Jeff, I want to thank you for a really terrific webinar today. Also like to thank each of you out there who joined us and provided some questions and attended and took part in this great sharing of information. We'd like to acknowledge our colleagues at the National Blood Clot Alliance for hosting this webinar, and very shortly you're going to get an email asking for your feedback on today's webinar, so please respond with your comments. If you have any additional questions about today's webinar, please contact Cynthia Sayers at csayers@cdc.gov. This webinar will be archived and the content will soon be available at CDC's Division of Blood Disorders website as shown on the final slide. Thank you for joining us today, everybody. Thank you, Jeff, and have a great afternoon.